Good afternoon, everyone. Welcome to PYA's Let's Get Rural webinar series. Today's topic is Navigating New Rules, Risks, and Reforms in Rural Healthcare. PYA is happy to present today's webinar on this important topic. Before we get started with the webinar, I'd like to go over a few housekeeping items. As this event is for 1.5 CPE credit hours, there are some additional steps that we'll take in order to comply with NASBA's request. Attendees will be provided 5 polling questions throughout today's webinar. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time to receive CPE credit for this course. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and post-event survey must be submitted for proof of participation today. We have posted a PDF copy of the presentation slides for your reference in the Resources pane. Also, you'll receive an email later today with a copy of the slides and a recording of the webinar. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. Your CPE certificates are downloadable via the CPE pane once you have completed the requirements. They're also sent via email after the webinar. You'll have the opportunity to submit questions to today's presenters by typing a message into the Q&A pane of the control panel. We'll collect these and address them via email after the webinar, and all the presentations will be recorded and released with a copy of the slides after the event. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Excellent. Thank you, Jennifer, and good morning, good afternoon to everyone. Thank you for joining us today. For those of you who are not familiar with PYA, we are a national healthcare consulting firm. And since 2021, we have sponsored a webinar series, Healthcare Regulatory Roundup. We generally have webinars twice a month on sort of hot topics in the regulatory world. And believe it or not, Kathy, next month we're going to hit episode 100 of HCRR.
It's been fun, Martie.
It's been fun. But we decided last year, beginning of last year, that it made sense at least twice a year to drill down on issues that impact rural providers in particular. Because so many of the issues we discuss, whether it's payment rates or conditions of participation or legislative agendas, there's always sort of that angle that is unique to rural providers. And so we wanted to provide, shall we say, a safe space for this next 90 minutes to focus in on those issues. And generally, we hold these webinars in July and December of each year. And this year, it was all about timing because here we are on July 10, and we have the bill, as I will refer to it right now, signed into law by the president on Independence Day. And certainly, there are a number of provisions in the bill that are going to have a direct impact on rural providers. So we will spend a significant amount of time talking about the Medicaid and the ACA premium tax credit issues, really drill into this new Rural Health Transformation Fund, as well as some other health care provisions of which you should be aware. Then we're going to talk briefly about the upcoming 2026 appropriations process, highlight the Medicare trustee report and what it portends for the future. Quickly through the 2026 Medicare Advantage final rules. The one piece of good news, guaranteed good news, is number 7, which is changes in the HIPAA privacy rule reproductive health care provisions. We'll touch on the team model and how it impacts rural providers. Then there's a host of recent CMS directives that Kathy and I will walk through to highlight issues of concern for rural providers. And then delve into the 340B program and what we believe are the administration's plans for that program based on the April 15th executive order. Kathy will walk us through MedPAC's recommendations regarding cost sharing for critical access hospital outpatient services. Thank goodness we have her because I can't make heads or tails of that recommendation. And then finally, we're going to wrap up with some discussion of clinically integrated networks, which has somehow in the last couple of months propelled itself to a hot topic in the rural health community. So we're going to start with the bill. And why I keep referring to it as the bill is because we really have not created a common usage on how we're going to refer to it in the press. But certainly the administration is very proud of this legislation. You have Russ Vought, the head of OMB, telling us that it's a home run and that there are no pros and cons. It is all good. I think maybe by the end of the day, you may have a bone to pick with Mr. Vought regarding the bill.
That
But
probably should have been our final polling question. Is it a good bill? Is it really all good?
Is it all good? Exactly. I would say to this quote, thou doth protest too much, maybe, if you have to sell it that hard. But anyway, so we're going to start out with a polling question. And as you know, these are attendance polling questions, but this is actually a very serious issue, is what do we call this thing in common usage? Part of the story is, if you remember the version of this bill that passed the House back on May 22nd, the actual statutory text called it the One Big Beautiful Bill Act. And from that, I started calling it OBBA because it's just fun to say. But what happened in the Senate is the Democrats, as they can do on a point of privilege, stripped the name out of the legislation. And don't worry, each party does it to the other every single time. And so there is no official statutory name for this bill. So we can't call it things like the Consolidated Appropriations Act or something like that. So with that concern, Jennifer, I'm going to turn it over to you to our first polling question.
All right, our first question is, how should we refer to an act to provide for reconciliation pursuant to Title II of House Concurrent Resolution 14, formerly known as the One Big Beautiful Bill Act, that was signed into law on January 4th, 2025? OBBA, OBBB, BBB, or Triple B, the 2025 Reconciliation Act, the Mega Bill, the Tax Bill, or other. Remember, you must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer.
And for those of you who respond other, please drop it in the chat. We are interested in your suggestions. Kathy, what did you call TEFRA?
Not take everything financially reimbursable away.
Yeah. No good acronym here, though.
No. Just like HMO is humble, modest, and overworked.
Okay.
Okay.
Well,
they're being really nice. The 2025 Reconciliation Act.
that's very straightforward.
Very
At least
straightforward.
we've had some influence. At least 30% of you agree that OBBA is just so much fun to say you can't resist it. So yeah, this is going to be interesting to watch as this shakes out. The one problem with the 2025 Reconciliation Act is that the Republicans were already talking about another round of reconciliation this fall. And so I guess we have to call it the 2025A Reconciliation Act, and the next would be 2025B Reconciliation Act. But
I vote that we stick with one of the others, and just and hopefully y'all will agree with me by the time we're done, is we're just going to call it bad.
Bad. Well, on that note, I'm still going to call it OBBA until someone tells me otherwise. So let's get started through our agenda. We're going to start with the Medicaid and ACA premium tax credit provisions. Why did we put these two together? Because these are the provisions of the bill that are going to reduce federal spending on healthcare benefits, and thus are going to have an impact on providers of all stripes because they are going to see declining declining revenue for those Medicaid patients you do treat, but more importantly, likely to see an increase in uncompensated care because fewer folks will be able to access these benefits, either Medicaid or the premium tax credits. So let's start with Medicaid, and we're going to talk about work requirements. We're going to talk about eligibility rules. We're going to talk about provider taxes, state-directed payments, and then sort of a hodgepodge of other provisions when we talk about this particular subject. So starting with work requirements. There have been 2 states that have had approved Medicaid state plan amendments to implement work requirements. That's Arkansas and Georgia. And Arkansas is sort of the lesson learned because they sustained their program for a couple of years and then gave up and literally said, we cannot manage this administratively. We're not seeing any measurable change in employment status among our individuals who are covered by our Medicaid program. Georgia still has its plan. It is also plagued with administrative problems, but they have forged through. And apparently that's what we're looking at, because beginning at effectively in 2027, so about a year and a half from now, states will be required to condition Medicaid eligibility for non-disabled, non-exempted individuals ages 19 through 64 on working or participating in qualifying community activities for at least 80 hours per month. So that is our requirement. The non-accepted category includes individuals who are caring for a dependent child up to age 13. That was one of the changes in the Senate bill where they narrowed that category down to just the little kids being part of the exception. There are also exceptions if you're in school and otherwise engaged in community activities, so that there's exceptions there. Though we have an implementation of 2027, the Senate bill, this final version of the bill, allowed states to request an additional 2 years to fully implement both the work requirements and the verification process. So they have to demonstrate to CMS they're making good faith effort in implementing these new requirements. HHS is directed to issue an interim final rule regarding the implementation of the work requirement by about a year from now, June 30 of 2026. Not a lot of ramp up period there. That's what we are going to be seeing going forward. That's an improvement over the House bill, which was going to implement this through guidance documents and have no notice and comment rulemaking associated with the work requirement provision.
But as an interim final rule, it will be effective as published, and then eventually we might get a final rule.
Yeah,
with
it's better.
comment.
It's better. It gives us some opportunity
Yeah.
into the APA. Exactly. And then $200 million has been appropriated in FY26 to assist the states with implementation. That money is to be distributed by CMS to support those activities. Let's drill down specifically on the state verification requirements, because that's the essence of a work requirement, is the state has to, in fact, verify that an individual who is applying for Medicaid or is going through the process of verification of eligibility is, in fact, meeting the requirement. So under the new statute, you have to get used to saying that, the state must verify an applicant meets the requirement at least 1 month prior to application, although states have the option of expanding that to 3 months. So an individual will have to have satisfied the requirements up to 3 months before they submit their application for Medicaid. Then once an individual has been enrolled in Medicaid, the state will then be required at each regularly scheduled redetermination verify if the beneficiary has met the requirements for at least 1 month since the last initial determination or redetermination. So the reason that this language is sort of clunky is that the general rule had been that you had to do redeterminations annually. And of course, we suspended that during the pandemic. We went about 3 years without doing any redeterminations. But now we're back to doing these annual redeterminations, except one of the provisions of OBBA that we'll talk about shortly is changing that redetermination process for what we call the expansion population and having to do re-verification every 6 months for that particular population. So again, for our expansion population, then we would be doing the redetermination, including the verification that they are in fact meeting the work requirement on every 6-month basis. And again, states can require additional months, more than 1 month since the last redetermination, and they can also elect to provide more frequent verification of compliance. So they literally could, go to every 3 months. We'll have to submit evidence of compliance with the work requirements. There is also an exception, thanks to the Senate, for short-term hardship. So these would not be exceptions, but they would be a demonstration of hardship by an individual that is covered by Medicaid. That would include a qualifying hospitalization, ongoing treatment outside of the county of residence, a presidentially declared disaster or emergency in the individual's county of residence, or demonstration that the county has a high unemployment rate, of course, making it more difficult for the individual to get a job. So we have added those exceptions as well. Bottom line here is the Congressional Budget Office, in reviewing this provision, determined that it will result in a $326 billion reduction in federal spending on Medicaid over 10 years. And a lot of the basis for CBO's determination is the Arkansas experience and the fact that when you have a work requirement, a lot of folks get caught up in the red tape. That they may in fact satisfy the requirement or satisfy an exception, but because of the frequency of redetermination, they do not maintain their Medicaid coverage, and thus they become uninsured. And so that's how we get to the $326 billion from CBO. Other eligibility requirements in the new statute. There were two final rules published by the Biden administration that were focused on eligibility and enrollment for Medicaid beneficiaries, intending to streamline the process and make it more automated and eliminate some of the redundant requirements, or at least they were identified as redundant requirements in this rulemaking process. As part of the legislation, these rules will be delayed until 2035. Not sure why we didn't repeal them, but we just delayed them through 2035. And CBO says here, this generates a $167 billion reduction in spending over 10 years. And truly, it's because people they can't maintain their eligibility, or they're never allowed to enroll, even though they would otherwise be eligible. Next up is effective at the end of next year. States must conduct eligibility redeterminations every 6 months for the expansion population. I previously referenced to this. CMS is to issue guidance now on these redetermination processes within the next 180 days. So we'll hopefully see those sometimes right after the new year. And CBO scores this at another $62 billion in savings. Also, starting in 2027, states will be required to phase in additional screening and verification procedures to prevent improper enrollment. So there were a lot of reports earlier this year of folks who show up being enrolled in two different states' Medicaid programs. They'll move from one state to the other, but they're not disenrolled by the MCO in the first state, and so they then re-enroll in the second state. There were issues of individuals who were deceased who were found on the Medicaid rolls. There were providers who were deceased that were still listed as Medicaid providers. And so new sets of requirements requiring screening and verification procedures to ensure that the right folks are on Medicaid at the right time. There is $30 million appropriated to CMS here for system implementation to make it easier to complete these verifications. But there is no money appropriated to the states, however, for those purposes. May be able to use administrative match there, Kathy. I would think they would, because states, for every dollar they spend on Medicaid administration, receive $1 back from the state.
Agreed. Agreed.
Okay. CBO scores this at $18 billion savings from closing what is probably fairly characterized as fraud, waste, and abuse issues. And finally, effective the beginning of fiscal year 2027, we'll have limits on eligibility for aliens, and no federal funds can be used for services furnished to non-covered aliens. This is a $6 billion reduction in federal spending. So that's one strategy, clearly, that the Congress has employed to reduce Medicaid spending, is simply making it, creating more obstacles to staying in the program. And sometimes those obstacles are legitimate, absolutely, that there are people that shouldn't be on the program that have been maintained on the rolls. But that's one way in which we're going to generate revenue. The other concerns the provider tax and the state-directed payments. And this is probably those provisions of which you have heard the most in recent weeks, in large part because of the difference between this approach in the House bill and the approach in the Senate bill. The House bill effectively froze where we are today. and said going forward, no new provider taxes, new restrictions on state-directed payments. And it still had a pretty significant fiscal note associated with it, the savings that would generate. But the Senate took a different approach, a much more aggressive approach to generate more savings, and in part claiming publicly that these provider taxes and state-directed payment were sort of like arbitrage, right? Or ways that the states could increase their money without having actually have to make an investment. But that's where we stand today. So let's talk about what is now the rules with regard to provider taxes. And briefly, for those who have not dealt with provider taxes on a frequent basis, Kathy, please add to this if I don't do an accurate description. But a state will impose a tax on certain categories of providers.
Mm-hmm.
It'll generate revenue. The state then uses that revenue to draw down federal matching funds.
Correct.
And then takes those monies and uses them for their Medicaid program. And in many instances, that includes increasing the rates for the providers who paid the tax. Mm-hmm. So yeah, you're right. You put in $1 and you get $1.50 back. Those are not actual numbers. Those are estimates. But this has been a tool that every single state except Alaska, right? Is it still Alaska a holdout?
I believe so.
Yeah, they use provider taxes for this purpose to generate that matching money. And CMS has routinely approved these provider taxes going forward. But what we see now will be the rules is a decrease in the threshold for the hold harmless provision. And that is at 6%. What it is today is 6% of net patient revenue. What that means is that in effect, I guess in practical experience, what it means is that the amount of the provider tax can never exceed 6% of the net patient revenue of the providers being taxed.
Mm-hmm.
If it exceeds that amount, then it becomes very, very complicated in terms of ensuring that the provider does not, in fact, pay more than it gets back. And so no state, at least to date, has exceeded that 6% cap because of the complicated the complicated accounting that would accompany going above that threshold. So, but what we're going to do now is decrease that threshold, meaning decrease states' ability to generate revenue for drawing down federal matching funds. And we're going to treat expansion states and non-expansion states differently with respect to this threshold. So starting with non-expansion states, there are 10 of us, right? There's still 10, Kathy? Yeah. And one in Florida, one in Kansas. So we're non-expansion girls right here. But non-expansion states can maintain the provider taxes that have been enacted and imposed out of July 4th, 2025, provided that CMS determined that those taxes were within the current threshold. But going forward, they cannot expand existing taxes nor impose new taxes. This,
as an example, with 6% being the cap, Florida's at 3.5. We can't ever get above 3.5.
We're stuck, exactly. And when we talk about the state-directed payments, you'll see there's some grandfathering provisions to protect current pending requests with CMS. That is not the case here. So your provider tax is your provider tax as it was on July 4th, 2025. For expansion states, then they are required to reduce their existing provider taxes to comply with decreasing thresholds. And like non-expansion states, they cannot expand existing taxes nor impose new taxes. This decreasing threshold begins in 2028 and goes down by 0.5 each year. So in 2028, it goes from 6 to 5.5 until eventually in 2032, we're at 3.5%. So each state takes stock of where its provider tax is today. And we'll say, okay, we're at Florida, you don't have to worry because you're at 3.5. But
if I am a non-expansion state and I'm an
expansion state.
I'm an expansion state and I'm at 4, I'm going to have to go back down to 3.5.
Right. And I would do it the first year because
Yeah.
No, I wouldn't. No, I wouldn't. I would not have to do it. Excuse me. My bad. I wouldn't have to do that till 2032. But if I'm at 6, then 2032, I go to 5.5 and down and down
Yeah.
and down. And of course, what that means when the provider tax goes down, the revenue available to the state to spend on Medicaid goes down, and it cannot draw down federal dollars. So CBO says this provision, this provider tax provision, will generate 191 billion in savings in the Medicaid program after the next 2 years. However, put an asterisk there because the CBO calculation was done on the original Senate Finance Committee version of the bill, which started the process in 2027 instead of 2028. It was during the floor debate that was changed from 2027 to 2028 to afford states another year of the higher provider taxes. And so CBO has not yet released its estimates on the final version. We're still working from the CBO estimates that were tied to the bill at the time debate started on July 1st. So we don't have the final accounting of what was changed during the actual floor debate. There wasn't a lot of changes, but this was one as we changed the date. So the 191 will come down. It'll be actually a lower amount to that. But again, compare that to what the House bill was, where it was $89 billion as a result of what was effectively a freeze, just the freeze on the provider taxes. So got it probably around, at least 90 billion more in cuts. And again, these are cuts, right? Because this is less money to the state to spend on Medicaid. So these are directly impactful. So let's talk about the other part of this equation, which is the state directed payments. So again, we generate revenue and we then use that revenue in many instances to increase payments made to providers. And we do that by directing our managed care organizations, our MCOs, to make certain payments to certain categories of providers. And we provide then the MCOs with the dollars to accomplish that. Again, states, when they submit a state plan amendment to do Medicaid managed care, part of the requirements is that they have to limit their imposition of requirements on the MCOs to pay certain rates, because the idea is we want negotiations between the MCOs and providers. But through a state plan amendment process, a state can say, we want to invest a certain amount of money, give it to the MCOs, and direct those MCOs to make certain payments to certain categories of providers. That's a state-directed payment. And they're frequently, in the last, probably since near the end of the first Trump administration, there was a policy shift in CMS to allow states to implement state-directed payments that would take rates up to average commercial rates. And a number of states were able to include improved payments to hospitals and nursing facilities and certain types of physicians up to average commercial rate for Medicaid beneficiaries. That was then finalized in regulation in 2024. But this is sort of the unwinding now of that policy decision made in the first Trump administration carried into the Biden administration. So now there could be no future state-directed payments that exceed 100% of Medicare rates. Asterisk, for our 10 non-expansion states, it's 110% of Medicare. Okay? So if you're going to do one of these state-directed payments to increase the payments made to certain providers, you're only going to be able to get those rates up to Medicare rates. And for certain services, there is no Medicare rate, like nursing facilities, right? Because they don't pay for the residential component of nursing facilities. So in that case, there would be the rate specified in the state plan, as opposed to the negotiated rate with the MCO. So for our current state-directed payments that exceed that applicable rate, a state must reduce their rate by 10% each year, beginning with the rating period on or after January 1st, 2028, until they reach the applicable rate. So if your ACR, average commercial rate, is say 130% of Medicare, and you're an expansion state, then 2028, it goes down to 120. 2029 goes down to 110. And then 2030, you find yourself at the Medicare rate. So again, it's going to be a decrease in rates for the providers that currently enjoy that higher derivative. It's either average commercial rate or often a derivative of average commercial rate, like 90% of average commercial rate. The request for new state, now this is where the grandfathering provision kicks in, because there were a number of pending requests for state-directed payments that were in various stages of approval by CMS. And so one of the compromises made on the Senate floor at the end of the debate was to say, if a state had submitted a state plan amendment by May 1st, it would be protected under the grandfathering provision. So they'd be able to implement their state-directed payment. And in fact, if the state-directed payment application was for rural hospitals, you actually got an extension to July 4th to accomplish that. And so that gives some cushion. So states like Nebraska and Tennessee that have had recently approved state-directed payments, or here in Kansas where we have one pending right now, they're going to be protected by this grandfathering provision. So those SDPs will not start declining until 2028. Also important to note here that there is an exception for nursing facilities and intermediate care facilities, in part because for those facilities, there's really no equivalent Medicare rate, but they've allowed any SDP that exists today to the benefit of a nursing facility or an intermediate care facility. Those may remain in place. So it's really targeted at the hospitals, targeted at the physicians certain physicians enjoy state-directed payments as well.
And Martie, let me just comment that on the first bullet, just to clarify, that 110% is for non-expansion states. Just notice that.
Yeah, you stare at these slides, and you miss to put the word non-expansion state. So Jennifer, make a note. We got to correct that. CBO says this is worth about $149 billion in reductions in Medicaid spending. Again, that's calculated on 2027 being the start date for the decrease. That was changed to 2028, so that CBO number will go down some. But still, compare that to the $72 billion of the state-directed payment provision in the House bill. So you're still talking, $80 billion more. And again, this is direct cuts to payments made to providers. There is also a provision in the Senate bill that closed a loophole about which 7 states have been taking advantage on a formula that's used to determine if a tax is generally redistributive. I can't even say that word. This provision in the statute is very similar to a proposed rule that CMS published on May 14. We assume the proposed rule will be pulled now because it's effectively been written into statute as part of this provision. Okay. The SDB cap, and again, we're giving you, CBO's looking at top line numbers. KFF, formerly known as Kaiser Family Foundation, has been analyzing the impact of the state-directed payment caps. Obviously, it's going to impact different states differently. You can see Florida down there, no impact because you're already at 3.5%, but there are 29 states that are likely to be affected. They're going to have to reduce down their state-directed payments. 2 more states that likely will be impacted, not certain because they've not published their rates. They've not released their rates publicly, so we don't actually know. And then other states that either don't have any SDPs in place or they're not targeting hospitals or nursing facilities. That gets us, Jennifer, to polling question number 2.
All right. Our second question is, how do you anticipate your state legislature will respond to cuts in federal Medicaid funding? Eliminate benefits, reduce provider MCO payments, raise taxes to make up the difference, or unsure at this time? Remember, you must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer. All right, thank you for participating in our poll. Now I'll hand it back to Martie.
Oh, they're still moving. Okay, there we are. I'm in the category of unsure at this time. What about you, Kathy?
Well, I think the way the question is written, unsure at this time could mean all of the above.
I like the 15% of you who are optimists that think the states will raise the taxes to make up the difference. But I think you may see definitely some local taxes for, county-owned hospitals, for example, some increases in those local taxes to maintain hospitals' services in the face of these declining Medicaid revenue. I think that's a hard question that a lot of county hospitals are grappling with is,
Right.
Can we really go to our population and say, look, we've lost this revenue? And it's a double whammy. It's not just you lost the revenue, you now have an increase in uncompensated care. So you still are providing the service and incurring the cost. You're just now not getting paid anything for it. And so how do you close that gap? If you want to maintain services in your community, kind of your last option is having a state, having a local tax that helps pay for it. But otherwise, it's just going to be, you don't realize this story is not over. I mean, the story is now going to repeat itself at least 50 times because every state's going to have to figure out how in 3 years or sooner are we going to deal with less money to pay for our Medicaid program. And if the pie is smaller, how are we going to cut it?
And one thing that was interesting in the comments in the Q&A, one individual made the comment, this was in a non-expansion state that is looking at expansion. This could basically be the end of expansion. Basically saying it kind of says, stay where you are.
Yeah, that's a great comment because one provision we didn't address because it was a fairly narrow impact is that there had been incentives created in the Inflation Reduction Act for states to adopt Medicaid expansion. And those are cut off as of January 1st.
Right.
And then also, if you are a non-expansion state and become an expansion state, you are now treated as an expansion state for all purposes under this legislation. So very clear on that commentary. We're not, and not only are we not done, this is a very concerning article that popped up, I guess, Tuesday. Senator Ron Johnson from Wisconsin, who is a deficit hawk, shall we say. That's probably a kind way of putting it, a deficit hawk. He was not pleased we did not cut enough for Medicaid. And he, along with Rick Scott from Florida, Kathy,
yes,
were the ones that were promoting a provision that would end the 90% FMAP for the expansion population beginning in 2030. So it would go for that population in the expansion, rather than getting the 90% match, they would instead go down to the standard state match. And so that truly generates some savings for the federal government. Appreciate that there are a number of states when they pass Medicaid expansion, they have trigger laws, meaning that there's any decrease in the amount of FMAP, it automatically reverts back to, they become a non-expansion state. They eliminate those individuals from their Medicaid program. So we'll see if he really wasn't, if we're really serious, because it was interesting that last week in June, this issue popped up, like the Scott amendment popped up, and then immediately got tamped down by leadership. But we've got folks who are still making noise saying that they were made promises that it would come back on the table. So there's still a huge piece. I mean, I know all of you were bombarded by advocacy requests from your state hospital association or your other professional associations. We're not done because there's still an advocacy component. Exactly. Because this would be, for states that have expansion, this would lead to some really, really, really hard choices.
Bites of the apple have gotten a lot of people in trouble in the past. Let's look at some other Medicaid provisions that were included in, I'm still going to say, as Martie is, OVABA. First of all, on the issue of retroactive coverage for the individual, depending upon whether or not you are in an expansion state or a non-expansion state, Essentially beginning in January of 2027, there would be retroactive coverage currently at 90 days, would be reduced to 30 days for the expansion population. And for those states that have not expanded, there would be a 60-day coverage period for new enrollees into the Medicaid program. So from a provider perspective, I think that is a really key issue to think about. The fact that the look back period, you had a patient who was in your hospital, you have now qualified them for Medicaid. It's that look back period that you would actually have coverage. For the expansion states, again, we are looking at a beginning in 2028, a $35 cost sharing for those individuals with incomes between 100 and 138% of the federal poverty limits. Recognize that when you start looking at that, this again becomes, in my mind, money that as a hospital you're probably not going to be able to collect, because I do not know that you're going to get that cost sharing paid at the time of service. And I also think when you actually look at it, the overall billing and processing of that $35 becomes burdensome on the provider. So very concerning about that. Also indicates that an individual state could impose a higher cost sharing for non-emergency services. So recognize that this could be worse than the $35. There will be collections of what they called erroneous Medicaid payments. This would be payment errors, overpayments, and such. They would be eliminating the special FMAP for emergency medical treatment for aliens. Prohibition on payment of medical funds to Planned Parenthood, but that originally, I believe in the House bill, it was eliminate period. Senate bill, it is eliminate for 1 year. I think we can go back to another bite of the apple, because I think this is something that they will be looking at adding, extending in future legislation. The nursing home staffing rule, there's a moratorium on enforcement of that through 2034. I think this is something that we thought was going to go away completely with the House bill, but through the Senate, we just have it extended, enforcement extended. And then an area that of major concern to me, because I've been monitoring this for a long time, and the Affordable Care Act, the ACA, there was a provision that was going to reduce Medicaid disproportionate share funding by $32 billion to the tune of $8 billion a year for 4 years. Essentially, what was in the House was that it would be pushed. We're going to push it again. It was pushed in 2014, then pushed every few years since. They were going to push it to 2028. What has happened in the Senate bill is they did not include that provision, and therefore, unless Congress takes action between now and the beginning of federal fiscal year 2026, we're looking at the first $8 billion reduction in Medicaid disproportionate share payments taking effect. So on top of everything that Martie has addressed in terms of cuts to the Medicaid programs, what we're also looking at is your Medicaid disproportionate share program taking a reduction, a significant reduction, beginning later this year.
Unless Congress acts again.
Unless Congress acts.
Yeah. Briefly, let's talk about the ACA Marketplace premium tax credits. Again, number of similar provisions to what we saw in Medicaid to make it more restrictive on who qualifies for the premium tax credits. So limiting eligibility for the tax credits to a very narrow class of aliens, requiring verification of specific insurance application information to qualify for premium tax credits, eliminating the availability of premium tax credits during income-based special enrollment periods. So an individual who loses their job today can apply for marketplace coverage and receive a premium tax credit to cover the cost of that. Now, going forward, with this as it takes effect, that premium tax credit would not be available until the annual enrollment period. They limit the definition of what constitutes lawfully present to qualify for premium tax credits. This is called the Dreamer provision. So a lot of we had allowed DACA individuals to qualify for premium tax credits. That will be discontinued now. And what's really missing here, the thing that is most concerning, is the extension of the enhanced premium tax credits that are set to expire at the end of 2025. As you know, since COVID, we've effectively doubled the size of individuals who are insured under a marketplace. And in large part, that's attributable to enhanced premium tax credits that have been available to individuals. But those are all set to expire at the end of 2025. There's no serious discussion right now about expanding those. And CBO tells us that's an immediate increase in uninsured. And by 2034, that's going to result in 4.2 million additional individuals not having insurance coverage. This is not part of OBBA, but relevant here because the provisions in this final rule that was published in early June were actually part of the House bill. They didn't carry over to the Senate bill because they had already been finalized in this rule. And this rule places a number of hoops that folks have to jump through to qualify for those premium tax credits. And the regulatory impact statement that CMS published with the final rule said that they expect that these will result in annual enrollment under the exchanges dropping between 725,000 and 1.8 million individuals. CBO, when they look at it, they said it's the equivalent provisions in the House bill would have left about 900,000 individuals uninsured. So to the extent you have individuals you're caring for today that are insured under an exchange plan, there's a significant chance, given the lack of enhanced premiums and now these additional eligibility requirements, that they are going to move into the category of uninsured. Again, creating a higher number of uncompensated care. And let's just finish up on that note is how does this impact rural providers? It is a double whammy of lower payment rates. So those folks that still have Medicaid, you're going to get paid less, but then it's also going to be an increase in uncompensated care as folks lose their Medicaid coverage. We are likely to see that. And there's the empirical proof of this because you look back at when the ACA took effect, what impact did it have on coverage? And through the vehicles that ACA provided, we saw the number of uninsured, the total amount of uncompensated care go down by about a third. And particularly concerning for our rural hospitals because we know that 60% of uncompensated care is furnished by hospitals. And then to make it worse, uncompensated care is more expensive than compensated care. How's that work? Well, folks who don't have insurance coverage tend to delay care, making their condition more serious, meaning it's more expensive. So you can take the same person, have one on insurance, one not on insurance, exact same conditions. This person's going to cost you more because they're not going to get any of the preventative care services. So what's the response to that? There's a limited opportunity for our PPS hospitals for expansion of DISH and bad debt payments. But again, that's going to be a drop in the bucket compared to what you're actually experiencing. There's always the idea that you can increase commercial payer rates to make up the difference. That's becoming harder and harder to do with employer resistance. As I referenced previously, increasing local taxes. But you also may be looking at reducing services if there are not options, especially the services that tend to be have negative margins, such as OB, unfortunately. And then taking a serious look at alternative payment models that there, in fact, now be a compelling reason to pursue alternative payment models to make up for the difference that you're seeing in fee-for-service reimbursement losses. Okay, so let's talk about something completely different. Let's talk about something that you may think is positive. Is the Rural Health Transformation Program. So this is added to OBBA in the Senate as a way to answer concerns about rural hospitals losing Medicaid revenue and the potential of that resulting in an increased number of hospital closures or service reductions. So even though that's why we have the fund, that's what it was intended to address, nothing in the statutory language ties payments under the program to those lost revenues. It is not in any way intended to be for a dollar for dollar or dollar for 25-cent replacement. It is not intended to make up for the loss of Medicaid revenue. These funds are not available to providers directly. Instead, they will be allocated to the states by CMS. That will be accomplished by the states submitting an application to CMS by no later than the end of this year. That application must include a detailed rural health transformation plan to accomplish the purposes you see here on the screen. So again, this is really new investment money is probably a better way to think of this, as opposed to making up for the difference in the monies lost as a result of the Medicaid cuts. So we're trying to reinforce rural hospitals, other rural providers with these monies to be strategically invested by the states who receive those dollars. And in fact, hospitals are required as part of those plans to provide strategies that they intend to pursue to protect the long-term financial solvency and operating models for rural hospitals. Interestingly, the CMS administrator who's in charge of this program, it's Dr. Oz's program, he has to act on these applications no later than December 31st. Now, it generally doesn't work to get the application in the morning and act on them by the afternoon. So what we expect to have happen is these applications will be due much earlier. Probably, I think, Kathy, we're looking at October, maybe November, for states to have to submit these applications. How dollars then are paid out based on successful applications. So each year, remember, there's $10 billion over 5 years, starting in 2026. So each year, the administrator will take $5 billion, half of that amount, and will allot it equally to each state that has an approved application. And so if everybody has an approved application, that means everybody would get $100 million. Now, that's kind of an issue. You're going, but wait a second, New Jersey and Rhode Island don't have any rural hospitals. But they do have other types of facilities that are defined within, that are included in the definition of rural health facilities, such as FQHCs, community health, mental health centers. There's no requirement that those facilities be located in a rural area. So there are opportunities for those states that have small number of rural providers to get the same amount as, Kansas with our 87 critical access hospitals. These allocations are made without regard to the number of rural facilities nor the financial condition of the rural facilities. It's just equally across the board. You all receive that amount of money. Then for the other $5 billion, the administrator will allot that money to not fewer than 25% of the states with approved application based on, for lack of a better term, need. And here you see the factors again on the screen that the administrator is to take into account in making those allotments, right? So again, if 50 states had approved plans, this administrator could allot funds to only like 14 of those states, and the others would be out of luck and not receive any dollars. Unclear at this point from the language in the statute, and trust me, I've read it a few times now, whether these allotments are all made at the beginning or if they are going to be made every 5 years to account for changes in circumstances. So it's either all going to be decided by the end of this year, or we're going to see that allotment change on an annual basis. Now, here's the concerning part. Very clear in the statute. The administrator's decisions regarding these allotments, regarding the acceptance of reports from the states on their allotments, the administrator's decision to claw back dollars that he believes that the state did not spend appropriately, none of those actions are subject to administrative or judicial review. The only review is political. So it is certainly of concern that your state is engaged early in this process, that it is in fact engaging with rural providers to ensure the strength of the application. that you are on top of this issue, watching very carefully what the administrator does with these funds, because it is literally a one bite at the apple opportunity. And certainly what we've been told, at least for those folks who are selling us on OBBBA, is that this is billions of new dollars coming into each state for their rural hospitals. But as you look at the detail, it is not that response to the loss of Medicaid dollars. It's instead more, how do we shore up these hospitals long term by making these types of strategic investments? But by the way, there's no way for you to challenge the decisions that the administrator makes with regard to these allotments. Once a state gets its allotment, it's then responsible for submitting a plan to the administrator on how they're going to spend the money. And that money must be spent on at least 3 of the 10 activities you see again specified on the screen. Again, the language of the statute makes it clear that these are the only 10. You have to fall into one of these categories for a state to spend $1 from the funds that it receives. And as I said previously, the administrator can pull back dollars if they don't believe they're being spent appropriately by the state. So again, as a rural provider, take a look at these. Where do you think the money can be spent most effectively? How do you engage with your state agency to say, this is the approach we need to take in our application to shore up our state rural providers, ensure their financial viability going forward? That gets us, Jennifer, to the next polling question. Still with us?
It does. Our third question is, do you anticipate funds from the Rural Health Transformation Fund will be sufficient to make up for lost Medicaid revenue? Yes, no, or unsure. Remember, you must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer.
Interesting, Kathy. This is all focused, this conversation around the fund, the program has all been focused around the Medicaid dollars and really no conversation around the lost ACA coverage.
Right.
Which is its own challenge for everybody. Well, it seems you all have some reservations about this.
No, they don't have any reservations. They're saying, no, it's not going to make up the difference.
So, not surprising results there. So,
all right, thank you for participating in the poll. Back to the presenters.
Okay. We're almost done with the OBBBA. One more section to go. Just some other healthcare related provisions of which you should be aware. Kathy, over to you.
Sure. Just a couple of things I wanted to touch base on. I know we're got a lot to cover and not a lot of time left. Under the House bill, there was going to be a change in the way they calculated the annual increase in the physician or adjustment to the physician fee schedule. What they're going, and it was going to be based upon the Medicare Economic Index, a percentage of that. What they have done instead is they're going to leave us in limbo. For 2026, there will be a 2.5% increase in the payment rate and the base rate for the physicians. This overrides what was included in MACRA, but recognize that the physician fee schedule proposed rule is sitting at OMB. We don't know if they've pulled it off and made a change, but whatever that proposes as an increase, the legislation calls for 2.5%. There will be high deductible health plans will be allowed to cover telehealth services and other remote services before the deductible kicks in. There for direct primary care services, the monthly subscription fee. Yes, Marty?
What about Medicare telehealth coverage, Kathy? Because that's what we're all worried about.
What about it?
It's not there.
It's not there.
Right now, it all sunsets on September 30th.
Everything that we have as it relates to the telehealth expires September 30th from the expansion perspective. Direct primary care. Go ahead, Marty.
No, go ahead. I interrupted you. I'm sorry.
Direct primary care, the monthly subscription fees would be considered a medical expense as opposed to an insurance fee, and therefore you would be able to use health spending accounts for those. And then workforce, very concerned about where this is going to take us overall from a workforce perspective in terms of new caps on student loans, and essentially looking at the unlimited grad plus loans would be limited to, it would be replaced with a $200,000 aggregate borrowing for doctoral, medical, and professional degrees. And it would cap the Parents Plus loans at $65,000 per student. Scary.
Yeah, you can't buy a medical degree for $200,000.
No. And so just very concerned about where this takes us overall. Appropriations?
Let's talk. So, okay, goodbye, Obaba. We're done with you now. Let's move on and talk about what Congress is going to do when it gets back from the August recess, because it gets to take 5 weeks off. I get a week off and Congress gets 5 weeks off. Okay, I'm sorry. I'm done complaining. Okay, President's proposed budget came out on May 30, and usually we kind of go, oh, it's the President's budget. It will never end up. We'll never see that. Obviously, it's a different game here. As we saw with Obama, that the administration is very influential, shall we say, with the other branch of government. So we're looking at this as something we need to consider very closely. But we are seeing HHS discretionary budget will be $95 billion, which is 25% less than its 2025 funding. There's a great deal of consolidation of divisions, as well as shutting down regional offices. And we have this creation of this new Administration for Healthy America, or AHA, as they are calling it, which, again, focusing on RFK Jr.'s prevention and chronic condition concerns. And bringing those into the spotlight. So we're going to kind of moving everyone around on the playing field, and we'll see what happens as a result of that. Specifically, if you look at the agencies within HHS, you can see it's somewhat uneven in how these cuts occur. The National Institutes for Health truly take it on the chin at a 40% cut in their overall spending. CDC is also looking at a 43% cut to their programs. Note, the Center for Medicaid and Medicaid Services, our good friends, are only seeing a 16% cut, which they say that's mostly due to redundancies. But what we pull out of that is the intention to reduce payments to the Medicare administrative contractors by 30%. They'll do everything the same. And in fact, in some instances, Kathy, they're going to have more to do.
Absolutely. They've already been saying we're going to take this from this agency and give it to CMS.
But according to the budgetary documents, that this reduction, it reflects efficiencies gained by descoping non-statutory workload and optimizing the level of effort. You all know how much we depend on MACs to, process claims and enrollment. And what happens when they're faced with a 30% reduction in their budget? This one's just not getting enough attention, because this really can disrupt the system significantly. So something to watch very carefully.
I want to comment on the MAC issue. I know a number of providers have their favorite MAC person who will always come to a statewide meeting, whether it be a Healthcare Financial Management Association, HFMA, or AHAM, or another group such as that, and will talk and share insights and answer questions. I don't think they're going to be out in the field anymore. They're not going to be able to do this.
Yeah,
very concerning, because that relationship that we've worked many years to build, we're not going to have.
Very concerning. As I said, if it was a long, hot summer, I'm not sure what's going to happen this fall, because there is so much outstanding to be addressed, and all issues of significant concern to rural providers, beginning with the core PPS programs, Medicare dependent, the threshold for low volume, the change in the base year for sole community, all of those. There is legislation pending. Senator Grassley had introduced a bill addressing all three of these. He tried to amend it into OBBA, but was not successful. But we'll see how Congress is going to address any of these. Specifically with low volume and Medicare dependent, we have the extension from the legislation in March. So we're extended through the end of this fiscal year. they're gone. Those provisions are gone September 30, just
Yep.
like our telehealth coverage, right? So either Congress steps in or we see that we revert back to the significant restrictions on coverage pre-pandemic, if you even remember them from 5 years ago. But the geographic restrictions, the location restrictions, the usage of certain technologies, all of that comes back into play. This House bill had included an expansion of the Rural Emergency Hospital Program for communities whose hospitals had closed prior to December of 2020. That did not make it to the Senate bill. So we'll see if there are any reforms to the REH program coming forward. Kathy mentioned our very favorite thing, the Medicare physician fee schedule conversion factor calculation. Will we see a long-term solution, or are we going to do this doc fix now every year like we did back in the early 2000s? Oh, I missed one. There's still a lot of conversation around reopening necessary provider designation for cause. So we have a lot of hospitals that are PPS hospitals in particular that are at risk, that cannot convert to CAW because of the distance requirements. Do we reopen cost status for a period of time to, quote, save those hospitals going forward? Kathy, you get to talk about site neutral. It's your favorite topic.
Well, and I know this is a program that is intended, it's Let's Get Rural, but site neutral would be applying not only to PPS hospitals and looking at their outpatient payments and equalizing them to physician practices or to ambulatory surgical centers, but also recognize that one of the areas from a rural perspective that they are looking at or have talked about from a site neutral perspective is, should we be equalizing swing bed rates to those of skilled nursing facilities? And what would that do to a critical access hospital in terms of their future financial viability if they took that lower payment for swing beds?
There's also concern, Kathy, with rural health clinics, because last year when they changed the reimbursement for care management for rural health clinics, they took all of those from a special rate over to the physician fee schedule rates. And in doing that, they said, well, they'll be fine under the Medicare physician fee schedule because it will cover their costs. And like, wait a second, you just missed the whole point of the rural health clinic program, is that the costs are more expensive in rural communities. So we provide the additional reimbursement. If you push us onto the fee schedule, you are forcing us into providing services at less than cost. So it's certainly an issue to watch here as we enter both the regulatory process and the legislative process over the next several months.
Price transparency issue on that. We're going to talk about price transparency in a few minutes, but one thing I wanted to mention on what we're watching, as opposed to what we already know, but price transparency, there was an RFI related to how can it be better and what can we do to improve reporting and making it more consumer friendly. I'm worried about what's the result of that RFI and what kind of comments are going to be considered submitted, and then what we're going to wind up having as impacts going forward. We know we're going to have another reconciliation bill, and got to have something. And then the one thing we don't have on the list, but I've said it to Martie, I think probably 5 times today, is I'm still concerned about sequestration, because when the House bill, right, Martie? When the House bill was out, the Congressional Budget Office came out and said, based upon this, we're going to have, it looks like absent congressional legislation, we would require that sequestration, your current 2% reduction in rates, go to 4%. They have not scored the current bill. So as it came out and it's been signed by the president, so I don't know what's going to happen with sequestration, but we have to keep our fingers crossed that it doesn't creep up again.
Yeah, for those of you who want to go into more detail on it, there's a really good Modern Healthcare article today, right, Kathy? Was it today or yesterday?
Yes.
Where it kind of goes through what the political machinations will be. This all ties back to Senator Graham's current status approach to scoring the bill on the deficit. So we really are in sort of a holding pattern to see what's going to happen with Medicare sequestration. Just imagine going 2 to 4% withheld for every single payment you receive. Great news. I like how we get to the point that we give really bad news and then we turn it over to Jennifer, right? That's our strategy here. So Jennifer, next question, please.
Our 4th question is, what do you believe Congress will do about Medicare telehealth coverage? Will extend waivers for another year, expand coverage permanently, allow waivers to expire, or I never predict what's going to happen in Washington, D.C. Remember, you must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer.
Getting smarter, Kathy.
Well, these folks, I was going to say they're really smart. Never predict.
Yeah, exactly. I did amaze my family when I said that bill will be on his desk by July 4, guaranteed. They thought I was some miracle worker. I'm like, no, this is what's going to happen.
All right. Thank you for participating in our poll. Now back to the presenters.
Excellent. Well, I hope we see good news. I hope those of you at 1 and 2 are correct moving forward. Kathy, okay, yeah, thought we had bad news. Keep going. Trustee
Okay,
report.
sure. I can keep going. You know that every year we get the Medicare Trustees report that basically talks about not only the future of the hospital insurance trust, but also the physician program, Part B versus Part A. Last year, they told us that they did not expect to see the hospital insurance program, the funding run out until 2036. This year, they have said, 2033, that the trust fund would be insolvent by 2033. And they have blamed this on higher projected spending for inpatient hospital services and on hospice services. So I think it's very interesting that these are the two areas. I'm anxious to see the focus on hospice in terms of the increased payments to hospice and what's happened there. They have said in the report that by 2027, they will probably have to start drawing down the reserves from the trust fund, and then recognize that insolvency would be a result in an 11% reduction in spending by 2033, and then that would grow to about 14% by 2049. The report does, as they characteristically say, they always say, hey, how can we fix this immediately? And so the comment was to maintain solvency for 75 years. We could immediately increase the 2.9% payroll tax to 3.32. Or we could immediately reduce expenditures by 9%. Let's just pile it on.
That's a Hobbesian choice, isn't it?
Yeah, hey, which one do you want? As an employee, you want to increase, have the employee and employer have the payroll tax increased, or reduce spending to providers by 9%. Interesting, on the Part B side, they basically said, we've had a lot of spending. It's significant, but we're okay. We can just raise the cost of supplemental insurance. Part B insurance, your Part B premium.
That's encouraging.
Yeah.
I'm going to make an executive decision. We have slides here on the Medicare Advantage final rules. I think I can summarize them like this. There were a number of pro-provider provisions in the proposed rules from the Biden administration, none of which, well, almost none of which were finalized by the Trump administration, who chose to instead buy some time to figure out where they wanted to move forward with the Medicare Advantage program. So all the issues we have with Medicare Advantage, we still are waiting to see some solutions there. There was an announcement in late June from the provider community, the payer community, pledging a series of reforms around prior authorizations. Many of these are consistent with the prior authorization rule that was published 2 years ago, but intending to clean up the process, really automate the process so that it's much less painful for providers. RFK thought it was a great thing. I think the proof is in the pudding. We'll see what moves forward as well.
Well, what's interesting is basically what they did was say, we're going to do what we've already been told we need to do.
Yeah, but at least they're happy about doing it now.
Well, and then one thing on that, I'm going to go back one slide, Marty, is just to throw, we've talked about what's going to be happening to your payment rates. Let's just go out and say that they did get a 5.8% 5.06% increase in the payment rates for payment year 2026. So
Yeah.
increase to the payment rates to the plans.
Yeah, and it's crazy because their payment rates are tied to utilization in traditional Medicare, which
Right.
went up, so they got paid more. Whereas our reimbursement, the provider community, our reimbursement rates are tied to costs, and we all know that our rates did not go up enough to come close to tracking what the costs increase. So something's not working there. HIPAA, reproductive health care. You know, back in 2024, we talked about changes to the HIPAA privacy rule, which were targeted on disclosures of protected health information relating to reproductive health. And most controversial in this new rule that went into effect was this requirement to obtain an attestation from those who requested PHI for certain purposes. There was legal challenges brought against this rule, and on June 18th, the judge in the federal district court in Texas ruled in the state of Texas's favor in a lawsuit challenging these HIPAA rules and claimed to, nullify the rule effective immediately. The opportunity to appeal this decision is there, but we know the Trump administration is not going to appeal the decision. Instead, there were a group of individuals who attempted to intervene in the case when it was at the district court level. That request for intervention was denied by the district court judge. That issue is now on appeal to the Fifth Circuit, whether or not it was appropriate to prevent these individuals from intervening. If the Fifth Circuit overturns that decision, then you've got the interveners who then could appeal the decision. But as it stands right now, today, providers do not have to comply with those rules requirements. So those attestations that you started collecting on December 23rd, I think that was the effective date, for now, you shut that process down. That is the only good news we're going to give you the whole time. Sorry, Jennifer, you don't get asked a question after that. So moving on. Team, Kathy, talk to you.
Yes, just very quickly, we talked about team, I believe, last year when we did our rural update in December, so I don't want to spend a lot of time on it. But team is a transforming episode accountability model. Essentially, it's a 5-year episodic payment model where they have identified a number of core-based statistical areas, CBSAs, that will be required to participate in this program. And it will be looking at overall payment for particular services for an episode of care. And that will essentially start with either an inpatient service or an outpatient service. You will be held accountable, either having the opportunity either to receive an additional payment if your total cost is less than a target price that you will receive later this year, or if your spending is greater, then you would owe money to the Medicare program. The services that are included are coronary artery bypass grafts, lower extremity joints, major bowel procedures, surgical hip and femur fractures, and spinal fusion. Why are we raising this with rural hospitals? First of all, rural PPS hospitals could be in this program. But from a critical access hospital perspective, it's the issue of swing beds. And what CMS said in their rule was that since cost swing beds are exempt from SNF PPS, they are reimbursed at a higher rate. Team participants that have historically utilized cost swing beds will be in a position to earn significant savings by establishing relationships with traditional SNFs and discharging patients they would otherwise move to cost swing beds to traditional SNFs. Bothers me from the time I read this, and it's something that I think you need to be looking at, arguing your case. If you are a provider with a swing bed and you are getting, let's say, patients who have had a knee replacement back into your community where the patient lives, where their family is, and now providers who are in team are saying, no, I'm going to go to a SNF. Recognize that there are costs that are incurred at a SNF that aren't counted in the SNF rate. Readmissions. That's not in the SNF rate. That's not being accounted for here when they say that you're reimbursed at a higher rate. The fact that the patient needed an MRI and was transported to a hospital where the MRI was done, both the transportation and the MRI are separate from the SNF spend, but within the critical access hospital. This is going to be done internally and a part of your overall costs. So I really think you need to be telling your story to any hospitals that are in the team model that you are working with, and to argue your case for why care is more appropriate in your setting. A number of directives that have come from CMS. I wanted to touch very quickly on transparency. We remember that the president had an executive order in February making America healthy again by empowering patients with clear, accurate, and actionable healthcare pricing information. And it called for disclosure of actual prices, not estimates, for all items and services. Also to increase, update the guidance related to standardization of pricing data and expanding enforcement. We still have not seen anything on enforcement, not a lot on the standardization, but there was one provision that came out in May. Back in January, we were told that if we did not have a calculated payment rate for a particular item or service from a payer, that we could encode 9 nines in our machine readable file that basically indicated that there was not a calculation for that particular rate. It was based upon an algorithm or a formula that we did not have any experience with, therefore could not calculate a rate. CMS expected that the use of the 9 nines would be infrequent. Well, no, there are those providers who used it for just about everything, and therefore one kid acts up and everybody gets blamed for it. So what they have now said is that you are required to have a dollar value, not 9 nines on your machine readable file. If you have had any historical activity with that particular payer for that particular service, you are to actually go back and use your remittances to calculate a payment rate. If there is no history, then go to your contract and figure out what you would expect to be paid, and also to include a footer that says 0 instances of the item or service in the 12 months prior to posting the file. The guidance came out on May 22nd. A lot of people reached out to CMS and said, when's this effective? How long do we have to do this? We got to do some work here. June 16th, almost a month after the guidance came out, CMS said this was effective May 22. And therefore, it is a requirement that you move forward and make sure that your machine readable file is does not reflect the 9 nines that were actually permissible in January. Martie?
So after the Hobbs decision, the Biden administration took the position that EMTALA trumps state law that does not have an exception in its abortion statute for the health of the mother. These circumstances where a woman comes to the ER and the doctors are concerned they have to wait until literally the woman's about to die before they can intervene. And the Biden administration said, yeah, no, that's a violation of EMTALA. There was litigation around that in the state of Idaho that is ongoing. But on June 3rd, CMS came out and rescinded the June 22nd guidance, indicating that the administration would not pursue EMTALA enforcement around issues of care for abortion care when a mother's health is at risk as opposed to mother's life is at risk. So just aware of the changing attitudes within the administration on that particular EMTALA related issue. Kathy, back to you on MA audits.
Yes, Medicare Advantage audits. Why do I care? These are risk-adjusted audits looking at the diagnosis coding that was used by the plans to increase their payment rates. They calculate the risk scores for the individual plans. And if the diagnoses are not validated, CMS could require the plans to repay dollars that were paid for to them previously. There has been a requirement that CMS audit the coding and the diagnostic information. However, they haven't been doing it. Therefore, they have decided that they are going to clear up the backlog from 2018 through 2024 by early 2026. They're going to use artificial intelligence or enhanced technology to review medical records and flag unsupported diagnoses. They're going to increase the workforce within CMS from 40 coders to about 2,000 by September of this year. And they're also going to be increasing the audit volume. They're going to be looking at all plans, not just about 60, and they're going to increase the number of records that they look at. Why do we want to share this with you? First of all, where are the records? They're with the hospitals and the physicians, and therefore they will be coming to you for the medical records to support the diagnostic information submitted by the plan. Secondly, I urge you to take a look at your contracts with the Medicare Advantage plans, because if in any way you are indemnifying them, yes, for the accuracy of the coding and the information in the records, then recognize that you could be subject to clawbacks. If the plans are required to repay CMS, they could, if your contract allows, come to you.
Hey, Kathy, let's jump forward to the copay because we got to get the question in time.
Sure. Very quick. Where is it? Here we go. Copay. MedPAC in their June report addressed the issue of beneficiary cost sharing for critical access hospital outpatient services. Currently, the co-insurance payment amount is 20% of charges. There is no cap. If you're receiving services in a prospective payment system hospital, then your co-insurance is 20% of your payment rate, not your charge, but 20% of payment, and it is capped at the Medicare inpatient deductible. MedPAC has identified that co-insurance equals about 52% of overall outpatient payment. Patient is responsible for more than the Medicare program is. And on average, the amount of coinsurance that was billed to beneficiaries at cause was about $1,750 compared to that $1,676 cap at PPS hospitals. So what MedPAC has proposed to do, or proposed to Congress, is that they reduce the cost sharing for critical access hospitals and outpatient settings to 20% of the payment amount on a per claim basis, and that there be a cap equal to the inpatient deductible, so that the amount that the patient owes would be more in line with what they're paying in a PPS hospital. This would result in less money from the patient, more money from the Medicare program. Expected impact when MedPAC looked at this, and when we start thinking about it, was it would reduce the cost sharing for the patient, and therefore your bad debts could go down. There's also an issue that was discussed very extensively within the MedPAC commissioners, was those beneficiaries who opt to not receive outpatient services at a CA near them, but actually to go further and go to a PPS hospital because they know they will not have this as high of an outpatient obligation, so that this could drive the business back into the community. It could reduce Medigap premiums for beneficiaries in states with a critical access hospital, but the Part B premiums for all beneficiaries across the country would likely go up because the Medicare program Part B is paying more. And as we mentioned earlier when we talked about the trustees report, the way we keep Part B solvent is keep raising the premium for Part B.
Jennifer, as quick as you possibly can, our last polling question.
Our last polling question is, do you support MedPAC's CAH cost-sharing proposal? Yes, no, or I need more information. Remember, please fill out polling questions in order to receive CPE credit. You will have 30 seconds to answer.
Not surprising. Most folks need some more information.
Yeah. And I urge you to take a look at the June 2025 report from MedPAC. It was a great discussion.
Our last topic we were going to discuss is addressing clinically integrated networks, or what's old is new again. We were just going to quickly summarize the Federal Trade Commission Department of Justice standards for clinical integration and joint contract negotiations. You have the content here on the slides. We also make reference to an article that we posted recently on our website going through those standards in detail of what is in fact required of a network of independent providers to join together to engage in joint contract negotiations. So that information is available to you there. So we made it by 1:30. Please, just information about PYA Center for Rural Health, how our professionals work together to provide best solutions for rural providers and the challenges that they face. And just in case you're curious, we have a newsletter we publish that sort of addresses all these wild changes. It's going on in Washington. You have in the resource pane a link to an article from our update that specifically takes a deep dive into the Rural Health Transformation Fund, if you want more detail on that. Otherwise, thank you all for joining us. We will see you back here in December for another Let's Get Rural. We'll see what exciting things happen between now and then. Jennifer, back to you.
Thanks to our presenters, Martie and Kathy. Later today, you'll receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Let's Get Rural series are available on our Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line to complete the short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.